So hello everybody, thank you for coming on this rainy Chicago fall day. I'm going to talk a little bit about the MPC and a little bit about what's going to happen when this grant funding is over. So as most of us know, the National Physicians Cooperative is a nationwide network of centers dedicated to preserving the fertility of their patients. Patients with cancer and other serious diseases whose progression or treatment is likely to impair fertility can receive the most up-to-date treatment and clinical research at MPC member institutions. And what we see here is a map of the U.S. As well as all of our MPC members, and we can see that we've really kind of spread out through the entire U.S. So the MPC actually started in 2007 with only 4 centers that really were only focusing on adult female fertility preservation options and really also focusing more on cancer. This is now expanded. We now have 74 MPC member institutions in 29 states, and also from a mixture of not only academic hospitals, but also community hospitals, private practices, as well as standalone cancer centers. So we really have grown and expanded. We also have participants from various fields of medicine, including REI, urology, pediatric oncology, hematology, oncology, but also from pediatric and adolescent gynecology, surgical oncology, pediatric endocrinology, dermatology, basic sciences, genetics, psychology, radiation oncology. So as more and more people are aware and we're expanding our focus, we've attracted many more fields of medicine, which is amazing. So what products does the MPC offer? So we have slow freeze media and kits, as well as our protocols that are available online and sample consent documents, which members can access and modify according to their specific IRB needs. We also have dissections, looking at how to properly dissect the ovarian tissue. We also have a fellow education curriculum, which many fellows participated in yesterday. We also have patient and provider pocket guides, as well as partnership with ASRM to provide e-learning modules on fertility preservation. And then some educational videos kind of geared towards younger children, including the new you, that's who, puberty, menstruation, as well as anatomy. The MPC has also published multiple books, including many on oncofertility, as well as fertility preservation and restoration for patients with complex medical conditions, again, kind of expanding what the MPC does. We're also currently working on an updated book that's more kind of a case discussion and presenting various cases. The MPC also has multiple publications in various types of journals, ranging from clinical journals to basic science journals, ranging from OBGYN journals to cancer journals to general medicine journals. So really kind of trying to encompass all different fields of medicine. You can see from the titles, they're also very different types of publications, from some clinical work to more basic science and translational work. We also have expanded beyond cancer into the transgender, as well as the DSD patient populations with works kind of focusing on that. A very recent study that was just accepted was by Austin Armstrong at the university, who is a medical student, that's looking at the evaluation of ovarian tissue cryopreservation usage in young females through the Oncofertility Consortium. Just a little bit about this newly accepted exciting study. So the study purpose for this study was to look at really our pediatric population, so prepubertal girls who froze tissue in the OC-MPC, and there were a total of 114 females who were examined. The reason why we chose to look at this age group is because this is really the only option available for prepubescent females, so we really wanted to focus on just the prepubertal options. So what we see here is that most of the patients had OTC for oncologic reasons. However, about a third actually had OTC for non-oncologic reasons, including hemoglobinopathies and DNA repair diseases, as well as other things that potentially could make, treatments could potentially make them infertile or subfertile in the future. What we noticed was that when you look at general populations and pediatric cancers in general populations, that there was some discordance between patients who were being referred for OTC and getting OTC versus the general population. We'll talk a little bit about why that is so in a second. In terms of our oncologic diagnoses, we found that leukemias and soft tissue sarcomas were the two largest, as well, and malignancies with the highest incidence in the OTC cohort and malignancies with the greatest representation in the OTC cohort correlated with the increased fertility risk due to treatment. So, although retinoblastomas are very, very common, we didn't have any cases of that, and that's because most of these kids are just treated with surgery that impairs no risk to fertility. So when we looked at cancer categories in our sample and then this year's data, we found kind of very similar distributions. And so we concluded that there were a sizable number of patients that were utilizing fertility preservation for non-oncologic conditions due to the disease itself or any treatments that would render patients less fertile in the future. And that most patients that were seeking OTC for conditions where treatments represent a high risk to future fertility. So meaning that the doctors were correctly identifying and extending these fertility preservation options to the patients at greatest risk and those that were in most need. So very reassuring study overall. So we have our repository. So from 2007 to 2017, so over 10 years, we have IRB approval from various sites that have contributed both ovarian tissue as well as data to this large repository of tissue and data. The repository is available to all MPC researchers, and in this repository we have clinical data from over 420 patients. We also have frozen ovarian tissue from a little over 100 patients, as well as formalin-fixed paraffin-embedded tissue. And this repository is from which a lot of our more basic science and translational studies have come from. So as most of you know, patients who enroll in the OTC have the option to enroll in research, which would mean 80% of the fertility of the cryopreserved tissue would go for the patient themselves to use in the future, while they agree to donate 20% for any basic science or translational research, so we learn more about what to actually do with this research tissue. So with the 80%, patients can later choose transplantation, which we just had a great lecture about, or perhaps emerging technologies, which we're actively learning about. And with the 20% research, we are learning more and more about experimental techniques, including in vitro follicle growth, as well as doing fixation and various histological analyses on these tissues, which have produced several publications. And as I mentioned, we do have IRB templates on our website that groups can use if needed. So since 2007, the number of research sites as well as tissues have continued to increase, while the median age of participants has decreased. So overall median age is about 19, but you can see here that over the past few years that most of the tissue samples that we're getting are patients who are between 10 and 15 years old. So this just kind of shows that in a more graphical form, that there has been kind of a decline over years in the age group that we're getting patients from. So overall, in looking at the cohort of all tissues, what we find is that most tissues that we're getting are from patients who have either gynecologic disorders, sarcomas, or other types of diseases. But what we also find is that we do get a fair amount of non-oncologic tissues, including from hematologic disorders that would require chemotherapies or other potentially ovarian toxic treatments. So why are we interested in doing this? So, ovarian, as Dr. Silber mentioned, ovarian tissue has been frozen worldwide for decades, and really we're not exactly sure how it can be used and the lifetime of the tissue, and to learn more about it. So nowadays when we freeze tissue, we do recommend freezing it in cortical strips, so not the entire ovary, but really dissecting the cortex and freezing it into strips. Most centers are still performing this type of surgery and cryopreservation under IRB protocols, but in the future, this may or may not still need an IRB. And as we mentioned again, the sample protocols as well as any support is available online. So what can we do with the cryopreserved tissue? So we just had a great lecture about the transplantation. An autologous orthotopic transplant has resulted in multiple human pregnancies. I think the number is probably around 100 or more at this point. We know that explants last about 16 months, and there is some concern, at least, in transplanting this tissue with women who have had a history of ovarian cancer and various other types of leukemias, lymphomas, or BRCA patients because of the fear of reintroducing cancer cells. The other thing that we could potentially do is in vitro follicle maturation, which Dr. Woodruff has made great strides in learning about how this can be done. So in terms of basic science, the MPC tissue has brought about multiple great breakthroughs, including the understanding of tissue transport criteria for both fresh and frozen tissues, and the ability to cryopreserve individual follicles. And this is really important because a lot of centers don't have the capability of freezing tissue, and so we've been able to kind of establish protocols or better understanding that tissue doesn't really need to be frozen right away, that it can be transported and frozen at a later time without a real loss in quality. We've also learned about the assessment of ovarian tissue that has led to the unexpected conclusion that the primordial follicle numbers may not be a great predictor for future fertility, and primordial follicles grow better when maintained in their cortical environment, and this was very much highlighted with our last lecture. We have also learned that human follicles can be grown in vitro to a large antral follicle stage and can actively produce hormones, including estradiol and progesterone, complete their ovulation, and form M2 eggs, all in vitro. We've also looked at the maternal age and found that there are oocyte changes, including a decrease in chromosome cohesion that in humans that's very similar to what happens in animal models, and other things that actually predate indicators of natural aging. So our ovary is probably the first organ to age before many, many other organs. So in the future, once this grant is ended, what we hope is to merge the National Physicians Cooperative with the Global Partner Network into a network that we're going to call OPEN, which stands for the Oncofertility Professional Engagement Network. The goal is for OPEN to bridge the gap between domestic and international programs and to establish a strong global network where members can share research, methodologies, experiences, and really build upon the framework that the MPC and the global partners have already established, as well as give a forum to maintain our subgroups, which have been very fruitful in these last few years. So with that, I will take any questions that people have.
I was intrigued by all that, and of course the question you might expect me to ask is, when you talked about the average length of survival of the explants being 16 months, that's sort of in contradiction with what we've observed, and I'm wondering whether it's the technique that's involved.
Probably. Yeah, probably very technique driven.
Okay, thanks.
Yeah. Mhm.
Do you have any?
If you want to talk into Kiwi.
Do you have some minimum requisites for the sites in United States to be part of the cooperative, or it's open? Because in Latin America we are open, but I would like to know if you have at least some minimum requisites to include new centers.
So not really requisites, but we do ask that any participating sites that participate in ovarian tissue cryopreservation do so under an IRB, and that was before, because now that the grant is ending, we're not really going to have that requirement anymore.
And another question, you told about some research, something that you were looking for. I would like to know if you already have results on the transportation of the tissue, if you know data about how is the best way to transport and to keep the tissue good for the surgery and for the cryopreservation.
Yeah. So what the paper looked at was length of time between collection and the freezing of tissue, and then looked at what the tissue looked like histologically if it was frozen right away versus frozen later. And I think that they found that 24 or 48 hours didn't make a big difference in what the tissue looked like. So which is very reassuring, because especially since right now we were advocating the slow freeze protocol, a lot of centers don't have that ability to be able to do slow freeze. And so the idea was to identify certain centers and then potentially transport the tissue there to be frozen, rather than have to require sites to have their own slow freeze technology.
Thank you.
Mm-hmm.
Any more questions?
Yeah, Michael Harris from Hackensack, New Jersey.
Hi.
I'm just wondering, on your contraindications, one of them was leukemia, and yet Dr. Silber has reimplanted a number of ovaries from women who had leukemia. Can you please clarify that?
So I think it's not, it's not an absolute contraindication. I just think that it's more concerning, because there have been lots of studies looking at mRNA levels of leukemias that have found they are present in these tissue explants. So I definitely think that it's a concern and something that needs to be further examined.
So I would just like to, just to follow up on that. So what would be the timing in a child, let's say, who has leukemia, to take her ovary out?
Well, ideally,
it's not ideally you would say, gee, at diagnosis, but I'm not sure
Right.
you would want to do that. So when would be the best time to do that?
So that's really when they're stable enough based on their oncologist. So ideally to try to preserve ovarian function, you'd want to do it before exposure to chemotherapy. But a lot of times with leukemias, patients are too sick and need to undergo chemotherapy right away. And so then the idea would be, once they're healthy enough to undergo the surgical procedure, once their blood counts are high enough and they're really given clearance.
Yeah,
Thank
you
you.
may not quite get it right, but the oncologist, before he lets you transplant it back many years later, not only is he going to do different PCR studies, he's also going to inject it into skid mice and see if they're transplantable. He's going to do a lot of tests, and if you didn't get it right, well then, your only hope then is by then you'll be able to work with these artificial systems you've
Right.
invented,
Right.
And I would recommend again, like I did earlier, this last question before this brought up, is you're not going to get everybody to feel comfortable doing the freezing. And I would encourage you to make your centers, or this place would be perfect, that people just send the ovary to you and overnight, and then they don't feel any responsibility anymore. It's very easy for them. Make it easier for them.
Right.
Mary Ellen, thank you for presenting that. Just a few clarifications on the topic of transport to one center. It certainly has been the case that Northwestern has accepted that responsibility for one site for storage and or for the IRBs, et cetera. The issue is that now that the grant will end, there's no way that the university has decided not to be indemnified for this process. We have talked with some of the other sites, particularly in the pediatrics, who may want to accept that. But right now, there is no single site that is going to accept tissue from outside institutions. But there may be some additional discussion, particularly I'm looking to Leslie and the Penn for some of their discussions over time. It is also the recommendation of the Oncofertility Consortium to maintain slow freeze for right now. So sites that are IRB approved do have slow freeze. We do recognize that there are new technologies that are coming out, and sites, as they retract their IRB to home sites, will continue to develop their own strategies. And of course, Mary Zielinski has been in the lead of developing that transition plan to new media and has been in conversation with several companies to try and develop an OC methodology that can be distributed with a plan for accepting that material. It is still the case that within the Oncofertility Consortium, the blood-based diseases are counterindicated. It is the case that Miro says that he, and I think Klaus had said that they were taking the tissues later, which you're now saying too. So that was something that I don't think was really clear to the field. But I think for most of the field, the common way that the Oncofertility Consortium has developed strategies was that the tissue should come out before the first sterilizing treatment, and that those tissues that have the high likelihood of transference of disease, because we do know that there are cancer cells within those tissues, should not be transplanted. I think these index cases are really important, and that we really understand when those tissues were taken. Again, this is new news, I think, for all of us, and we really want to understand that a tad better, because certainly when we take the tissues out, there are cancer cells that are there, both prior to chemotherapy and after chemotherapy. So these represent the reason that I think our field has to stay coordinated and to bring us together in ways so that we understand when things happen, how that's being done, to enable all of us to make good decisions. And I will just say one other thing. There are a number of oncologists in the room. We're delighted you're here. But I guess I would just press back on one point, and I think that it is incumbent on both the oncologists, reproductive specialists, and I'm not going to stop with both. It's incumbent on all of us to really think through these issues. I don't think the oncologists are going to be prismatic in their knowledge of whether or not that tissue can or cannot be transferred. And I do know that Dror has studies where you look at different pieces of the tissue, and certainly within the MPC, you've seen in our literature that if you cut the section, you can find cancer cells that are asymmetrically, that are not distributed uniformly across the tissue. And I think that represents the concern that we need to address as a community in order to make sure that when these procedures become more routinely available, that we can really define very carefully who is a good transplant individual and who might have a higher risk, so that that individual will know what that risk might be. So I think the data that you presented to us and the descriptions are really important, and the consortium will take that back into our subcommittees and continue to work through that data and apply these large index case studies, 420 cases throughout the MPC. And certainly I think the Penn is interested in doing some of this, and some of you in the room have accessed the tissue to look at various questions. But those are the kinds of things that we really need to get very, very firmly in hand to make sure that whether or not you use an existing simple transplant, or if you're going to have to move to one of the newer kinds of transplants to mitigate or minimize risk, that we really understand what that looks like. That would be my thoughts.